So what we are looking at here, going back to our basics, remember from the first part of the term, is a scanning electron micrograph of the functional structure of the kidney called the glomerulus, which students have a really hard time saying. Fortunately for you, I don't care how you say it, as long as you spell it correctly. So glomerulus, that's how you say it. So this is a specialized capillary bed, essentially. It's all arterioles, no venules. And it's also under pressure so that fluid is constantly leaking out. So when I talk about stuff being blood filtrates, things like urine and things like cerebrospinal fluid, et cetera, what I mean is blood under pressure and plasma being forced out. And are they really green and blue? Absolutely not, but it's helpful to resolve structures if we impose false color on them. So that's what's going on here. Okay, so your urinary system is one of the two most powerful waste removal systems in your body, the other, of course, being the digestive system. And I do want to take a moment here to state unequivocally that between your liver and your kidneys, you have a very powerful onboard detoxification system, which is oodles more powerful than, wellness trends like drink only juice for a while or what have you. So if you encounter in your lives any person that's like, oh, I need to blah, blah, blah detox, and they're looking to spend a bunch of money on some product to help them do that, perhaps remind them that they've got an onboard system for that. And assuming they haven't destroyed it, it should just be enough. Okay, so one interesting thing is that the urinary system is embryonically associated with the reproductive system, which is why they kind of overlap in the pelvic cavity, and why birth defects of both systems often result in a weird merger or adhesion between a urinary structure and a reproductive structure. So this is why there's some overlap between reproductive medicine and urology, because embryonically, they all come from the same set of tissues. So we call them the urogenital system for that reason. And the urinary system, once it's mature and functionally distinct from the genitalia, consists of two kidneys, one per side, unless you have a horseshoe kidney, more on that later, two ureters. And the ureters are these tubes that carry urine from the kidney to the bladder, not to be confused with the urethra. That's how urine gets out. And then the urinary bladder is basically a pouch of smooth muscle that stores urine until it's the appropriate context to void it. So the reason that we're not constantly dribbling urine is because we have a storage area for it. However, neurological damage can produce a phenomenon called automatic bladder, where you're just kind of constantly peeing a little bit, and I'll explain that as well. So as far as function is concerned, we're going to talk a lot about that, as well as, of course, anatomy, and then how exactly urine is formed from the filtration step that happens at the glomerulus, all the way through the renal tubules, which are a series of epithelial tubes with lots of different pumps in them. And what they do is they capitalize on secondary active transport primarily to move stuff that's useful out in or back into the blood and move waste products into the urine. So that you can tell a lot from looking at people's urine, because ultimately it comes from the blood. So you can make inferences based on urinalysis. So we'll talk a little bit about, what kinds of things you can tell from urinalysis and other renal tests. And then finally, we'll talk about the urine storage reflex, which, yes, it is a reflex, and the micturition reflex, which is a reflex that allows you to pee. So let's zoom out first and talk about waste disposal in general. So the respiratory system gets rid of the waste product CO2. But of course, also, I want to be careful about characterizing CO2 as only a waste, because yes, it is a byproduct of metabolism. However, it's also useful and integral in our blood buffering system. So it has this other role as a helpful pH balancer. You also breathe out water vapor, so that's a waste. The integumentary system does have a role in waste secretion, but it's not by any means primary. So no significant detoxification happens across the skin. It's really the digestive system and the urinary system that are the stars of the show here. And so via the digestive system, anything you don't use from your food, metabolic waste, extra cholesterol, bile pigments, which we discussed previously, are metabolic waste products of disposing of hemoglobin, all kinds of stuff here. And then the remainder is urinary system. So this includes breakdown products of metabolites, any toxins that you may consume, drugs. This is how hormones get cleared from your blood. So we'll talk more about that when we get to the endocrine system. And then salts, hydrogen, a cation. So this is how we get rid of most of our acid, and water. In fact, apropos of what I was talking about with detoxing and what JD is saying in the chat, I just had a difficult conversation with somebody I know because they are trying to do the sort of alkaline diet trend where people tell you that you're too acidic and that's why you're not feeling good, and you have to alkalinize things and drink alkaline water and a bunch of other stuff that doesn't make any sense. And we had to have a little talk about how to detect pseudoscience and when you should and shouldn't be spending money on things like that. It was very difficult to dissuade this person from the idea that the source of all of their woes is acid. I was like, you've got a really effective acid disposal system already. You don't need to buy water that is pH 8.5. There is no point. It hits your stomach and gets neutralized by your stomach acid. But we'll talk more about that later. All right, so why have a urinary system at all? Well, the primary reason is that waste products of metabolism that contain nitrogen are unusually damaging to our cells and tissues. And so we need a way to get rid of those. And one of the major reasons for that is that we rely on proteins to operate our metabolic processes on a daily basis. So all of the metabolic enzymes that we rely on to break down food into micronutrients and perform enzymatic reactions, et cetera, all of those are proteins, as are our transmembrane proteins, but proteins wear out. So we have to constantly synthesize new ones, which corollary to that is that we have to constantly get rid of old ones. And that requires nitrogenous waste products because amino acids have an amino group. So deamination is when you remove the amino group, and that forms ammonia, which is very bad for us. You should not have too much of that in you. And the liver converts that ammonia to the less toxic urea. So here we have another link between the digestive system and the urinary system. Your liver is critical for this process, and if it's not working properly, you won't be able to do it very well. So there's this kidney liver link again. Uric acid is a product of nucleic acid catabolism, so breaking down nucleic acids. You also have creatinine, which is the byproduct of creatine phosphate. If you're not familiar with creatine phosphate, here's the quick and dirty version. Creatine phosphate has a spare phosphate that can be used to generate ATP in the intermediate energy usage stage of skeletal muscle. But once that happens and the phosphate is removed, then you just get creatinine, and that has to be disposed of. So blood urea nitrogen is a way to express the just total amount of nitrogenous waste in the blood. And so this is something that you might check if you suspected, for example, that your patient was experiencing renal failure. So normal blood urea nitrogen is between 10 and 20 milligrams per deciliter. So that's a pretty decent range. It is obviously going to vary according to a variety of things, including your diet. So if you're eating a crap ton of protein in addition to other stuff, you might have a higher end bun, but it shouldn't be much more than this. If you get an elevated BUN, we call that azotemia, which basically is a way to say there is too much nitrogenous waste in your blood, and that indicates that your kidneys are not doing their job completely. And then uremia, this is really, really bad. You get diarrhea. There, I said diarrhea again. How many times this class will I say it? Vomiting. Dyspnea is a way to discuss aberrant breathing patterns and cardiac arrhythmias. And this is what happens when nitrogenous waste builds up in your blood. It's really, really bad. It affects multiple systems, and your organs begin to shut down pretty soon. So this is when you would need to undergo hemodialysis and or kidney transplant. And then just if you're not familiar with dialysis is basically they take your blood out of you, they clean it in a way that your kidneys would, and then they put it back in. Depending on the amount of renal insufficiency, some people have to go do dialysis like every day, and it takes a really long time. So it's not a small deal. It's very impactful on patient quality of life. And most people that are on dialysis, it's not a good long-term solution. So they're on waiting lists for transplants. And meanwhile, they have to go get this thing done that takes a bajillion hours every day. So dialysis clinic is not a fun place to be if you have to be there for that reason. Okay, so what exactly do the kidneys do? And we'll also look at kind of where they're located. So one of the things that they do is filter your blood plasma. And so I want to emphasize plasma here. Erythrocytes and white blood cells, which also circulate, as well as large plasma proteins, they should not be entering the filtrate. They are kept in because they're too big to leave the glomerulus. If you see those things in the urine, that's indicative of infection. How much or little you urinate regulates your blood volume. So if you're peeing out a lot of water, you would see your blood volume decrease. And if you're not peeing very much, you would see your blood volume increase. The major link between those two things is something called the renin-angiotensin-aldosterone system, which is a series of hormonal steps that help to reverse a loss of blood volume. So we'll talk about those when we get to the endocrine system. And it also regulates body fluid osmolarity. Osmolarity is a big deal because the osmotic pressure of a fluid can cause fluid to move from one body compartment to another body compartment in a way that could threaten the health and well-being of your patient. So this is why some of you may have some familiarity with this. If you are administering IV fluids, for example, or drugs that come in an IV bag, et cetera, it's your responsibility to make sure that you pay attention to whether they are hypertonic, hypotonic, or isotonic solutions compared to body fluids. Because if you mess that up, you can mess up the osmotic pressure of your patient and cause inappropriate fluid movement, which can threaten their well-being. So it's a basic biology principle, but in a practical sense, it matters a lot. Renin is part of that renin-angiotensin-aldosterone system. And we'll talk more about that, but basic idea is it alters your blood pressure. increases it. Your kidneys also secrete erythropoietin, which is what causes your red blood cells to be produced. It's contributing to your acid-base balance via scrubbing protons out of your body. The final step of making vitamin D, specifically calcitriol, which is the most active form of vitamin D, involves the kidneys. And that process, by the way, starts in your skin. So the vitamin D synthesis that you experience is a multi-organ system endeavor. And then finally, if you are starving, so not normally, but if you are starving to death, your kidneys actually can help out your liver by doing some gluconeogenesis themselves. So glucose is gluco, neo means new, and genesis means to make. So gluconeogenesis here means, oh my God, we're about to die. Quick, let's make some glucose out of something that's not glucose. But under normal physiological parameters, that should not be happening. So here are some kidneys, and I like this side by side because we can see the actual anatomy versus the cute illustration. Obviously they resemble each other, but as you can see, of course, you know, in an illustration, we've got these nice orderly looking renal pyramids and everything is sort of plump and evenly spaced. This is not quite that. You can see we've got confluent pyramids, which is pretty normal. But other than that, yes, I agree. It does look pretty similar, especially if you do what's called double injecting of the kidney, where you inject the arteries with red latex and the veins with blue. So here we have and I'm kind of running my cursor along it, the area that urine first drains into. But if you look, like next to that, in between, there's this space. Those are the renal sinuses. It's just the area of the kidney that is not collecting urine. It's between all that stuff. Ordinarily, it's filled with fat, as well as other stuff. So like blood, lymphatics, etc. The renal parenchyma is the name for the sum total of the glandular epithelial tissue that forms urine. So like many things, the parenchyma is organized into the cortex and the medulla. And in this case, instead of having one unified medulla, the medulla is organized into these little pyramids, which are these areas of darker tissue. So the cortex is where you find glomeruli and where you find the renal tubule, the proximal and distal convoluted tubule. The medulla is where you find the urine concentrating apparatus, so the loop of Henle and the collecting system. And then the lobe of the kidney is one pyramid and the cortex that overlies it. So now I need to get into major and minor calyces. So I want to make a point here. Calyx is singular, calyces is plural. So off of the tip of each renal pyramid, that tip is called the papilla. So remember when we were talking about the integumentary system, I mentioned that papilla means nipple, and there's lots of different kinds of nipply named things all over the place. Here's another one. So renal papilla means kidney nipple. And it's really the sort of nipply shaped protuberance of the renal pyramid into the minor calyx. So this is a cup. It's lined with transitional epithelium, and it basically collects the urine from one piece of the medulla, basically. I also hope whoever was walking by heard me say kidney nipple and were like, I need to go look that up. Although I shudder to think what that Google search result would look like. So major calyces are when two or more minor calyces join. So this is a major calyx because it's drained into by 1, 2, 3 minor calyces. And then the renal pelvis is what collects urine from all of the major calyces. So it's kind of like small streams and creeks that are tributaries to a river, same idea. Oh, that's funny. Well, perhaps later you can explain to your roommate what a kidney nipple is, or you could let it be a mystery. That might also be fun. Who knows? So off of the renal pelvis, we've got the ureter, and this is what carries the urine to the bladder. So the ureter is primarily transitional epithelium. There is some smooth muscle in the wall of it, as you'll see, but mostly urine gets to your bladder by gravity, not much by peristalsis. And of course, if you have a kidney stone, the horrific lower back body wall pain that you experience from kidney stones is a spiky ball inching its way down your ureter. More on that later. We'll look at some different kinds of calculi in a bit. Okay, so let's talk about this header up here, because I can't stress enough how disproportionate the vascularity and blood supply of the kidney actually is. So we've talked about the circulatory system, and we've talked about things like cardiac output, so the amount of blood your heart's moving out, and all that kind of stuff. And it's easy to fall into the assumption that all organs and tissues are perfused with blood equally. And that's absolutely not true. So from moment to moment, not all of your tissues are getting the same amount of blood. And regardless of your level of activity, your kidneys get a disproportionately large percentage of cardiac output, so how much blood your heart is moving out, precisely because they are there to filter the blood. So they need to get a lot of the blood in order to filter a lot of the blood. So the reason, or one of the reasons I'm stressing this so much, is of course because due to this, injury to the kidney is a very life-threatening situation from a clinical perspective. So similar in nature to how I discussed the spleen. Remember that, where I was like, the spleen is weird because you can totally live without one, but if your spleen gets stabbed or crushed, you die almost immediately from internal bleeding. Same deal with the kidneys, even more so. So the kidneys are what are called retroperitoneal, meaning they are sitting on your back body wall, relatively close to the surface of the lumbar area of your middle back, which makes them a little bit more vulnerable to injury. So for example, let's say you are working in the trauma part of the emergency department and you have somebody who has experienced a body wall crush injury, maybe due to a car accident. Your primary concerns should be checking for lacerations. So basically pressure splitting of the liver, the kidneys, and the spleen, because those are going to be the things that threaten your patient's life and survival the most directly if they're not addressed immediately. Yeah, exactly. I mean, so people don't understand what laceration in the context of organs means. So we think it means like slicing or cutting, but really most oftentimes it means that one of your organs was slammed into so hard that it splits and like kind of splits open, which is very, very bad. So car accidents can cause this. Ski and snowboarding accidents are also a significant cause of kidney and spleen trauma, as well as skateboarding. So basically all the cool fun things are pretty dangerous to your kidneys and your spleen, unfortunately. So let's talk about the blood supply. The renal artery comes off of the abdominal aorta, and it splits into the interlobar arteries, which do what they sound like. They go between lobes. Those, well, first you have segmental, which interesting fact about segmental arteries, the number of these varies from person to person. Some people don't even have them. So this is a little place where there's some phenotypic plasticity in humankind. It doesn't really matter how the blood gets to the lobes as long as it gets there. So some people have segmental arteries, some people don't. The interlobar arteries go up between each lobe. And then the arcuate arteries are called that because they're shaped like arches. So they arc up around the top. And then radiating off those are these little sort of pokey outy branchy guys called the cortical radiate arteries. So they are radiate because they radiate like rays, and they're cortical because they're in the cortex. So the cortical radiate arteries give rise to the afferent arteriole, which is the entrance vessel for each glomerulus. And then the efferent arteriole is what leaves. The efferent arteriole gives rise to the peritubular capillaries. Peritubular means around the tubules, and we'll zoom in on these a little bit later. The vasa recta is this ladder-shaped piece of peritubular capillaries. The vasa recta is just the name for this ladder-like shape, but it's still considered peritubular. And then, as you can see, this is where gas exchange happens. So now we finally have oxygen-poor blood, and those drain into the cortical radiate veins, and then the cortical radiate veins, also called interlobular veins, drain into the arcuate veins, the interlobar veins, and then the renal vein, culminating in the inferior vena cava. So understanding the path of blood through the kidney is important clinically because that's how blood gets to be filtered. So make sure you're on top of that. And then with regard to this renal circulation and disproportionate receipt of blood, one issue is that if you are an extreme exerciser, what ends up happening is that so much of your cardiac output ends up being shifted over to your heart, lungs, and skeletal muscles that essentially your kidney doesn't get as much blood as usual. So you're not making as much urine as you would be under those conditions. And that makes sense for a variety of reasons. One of them is that exercise induces your sympathetic nervous system to increase in tone. So it's not the same thing as fight or flight acute stress response, but it activates the same neural pathways, which sort of downregulates the importance of waste production. And so in extreme cases, like if you're an ultramarathon runner, for example, you may experience transient proteinuria or even blood in your urine afterwards. That's because the kidney is not being perfused and the glomerulus becomes hypoxic and begins to deteriorate a little bit. Fortunately, all of this stuff is epithelial, and epithelial tissue has high rates of regeneration. So you recover from it. It's not permanent, but extreme exercise does often have urinary outcomes. So each kidney contains about 1 million nephrons. And a nephron is the renal corpuscle plus the tubule associated. So the renal corpuscle is the glomerulus plus the capsule that it surrounds it. And then the renal tubule is the proximal convoluted tubule, which is proximal to the glomerulus, the loop, and then the distal convoluted tubule. So the reason that we discuss these as a unit called the nephron is because from the afferent arteriole all through these structures, we go from having just a simple blood filtrate to having fully formed urine. So it really is the functional unit of the kidney. The action and operation of all of your 1 million nephrons together is what allows you to produce urine. So here's the path once more. We've got the renal corpuscle, and the capsule of the corpuscle collects the new filtrate, and that filtrate heads into the proximal convoluted tubule. We'll talk about what goes on there later. The loop of Henle, which is this loop-like apparatus that descends into the medulla, that is responsible for some countercurrent multiplier action, which concentrates your urine and really effectively gets salt and water back out of the filtrate, because sodium, chloride, and water are very important for us. So we have the thin descending limb, the thin ascending limb, and this part well, we'll explain it later, but it has a different permeability from the thick portion. This part is water permeable, this part is salt permeable. The thick ascending limb, and then the macula densa area, and I'll show you the histological significance of the macula densa. It's a sodium sensor. And then we have the distal convoluted tubule, the connecting tubule, which is just a short connector bit that connects it to the collecting duct. And then finally, the collecting duct descends through the medulla and dumps urine into the minor calyx. So here we have our little renal corpuscle here. So the glomerulus is a really impressive apparatus. It's constantly under higher pressure than other capillary beds, which means that the hydrostatic pressure of the blood pushing on the walls of the vessels forces fluid out. And so, by virtue of that, you're constantly filtering your plasma. So it's not like you filter it sometimes and not others. There's a constant trickle of plasma out, forming filtrate, which ultimately forms urine. So in each and every corpuscle, you have what's called the vascular pole, which is the end of the ball where blood comes and goes. And you'll notice that the afferent arteriole is larger in diameter than the efferent. So if you allow the entrance to be large and the exit to be small, that's what keeps the pressure in here high constantly. So it's just a matter of different tube widths. And it's a really cool and elegant way to keep the pressure in here high. The urinary pole is the opposite pole, and this is where you have the entrance to the proximal convoluted tubule. Nestled in the crook between the afferent and efferent arterioles is the specialized area of the distal convoluted tubule called the macula densa, which you can see right here. And macula means spot and densa means dense. So it's Latin for dense spot. And that's reflective of the fact that the nuclei of these cells are just kind of smushed closely together, as you can see. So we'll talk about what this does later. It's in the same place on every nephron. It senses sodium and makes adjustments to filtration based on what it detects. But keep in mind, this structure is spherical, which means that if I were to cut it this way along this axis, you wouldn't see the urinary or the vascular pole because I haven't sliced it at the correct angle. So all that is just to say, when you're looking for structures in lab, keep in mind that what is being sliced is a wad of tubes, including some spheres. And depending on the angle of the cut, you may or may not see certain structures. So keeping three-dimensional structure in mind when looking at light microscopy is an important thing to sort of show mastery. Excuse me. So glomerulonephritis is inflammation of the kidney, specifically the glomerulus. And glomerulonephritis can happen for a variety of reasons, but probably the most common and ubiquitous cause is diabetes mellitus. So these are actually linked. So you can get glomerulonephritis secondary to diabetes. Also diabetes and hypertension both, if they are not managed, will damage your kidney. So a lot of people who go to dialysis are in dialysis because their diabetes and or high blood pressure was so poorly managed that they ended up with glomerulonephritis and kidney damage that reduces their kidney function. But regardless of the spectrum or combo package of problems that they're experiencing, the pressure in the glomerulus is altered and the cytoarchitecture of this structure is altered so that the glomerulus becomes leakier than it should. So what you end up with is proteins like fibrinogen and albumins from the plasma in the urine, and that gives you proteinuria. I do want to stress, however, that most people experience transient proteinuria at various times in their life. So if you see proteinuria, it's not a definitive indicator or diagnostic definer that your patient definitely has diabetes or definitely has glomerulonephritis. But if that would be combined with other clinical observations, then you would come to those conclusions. So it's not the be all end all diagnostic tool for those things. I just want to stress that. So other people who experience transient proteinuria, distance athletes, like I just mentioned, also pregnant people tend to get proteinuria because there's unusual pressure on the kidneys and changes to circulation when you're making and carrying another human being. And people on the ketogenic diet who are consuming crap tons of extra protein and fats end up with proteinuria as well, just because the protein exceeds the transport maximum of the kidney. So those things are not life-threatening, obviously, but they are going to cause proteinuria. You can check for proteinuria in yourself by looking at your pee. If your pee appears foamy, that is indicative of proteinuria. But you have to make sure if you're diagnosing your own urine that there's not some like toilet bowl cleaner that you're kind of just peeing against that is frothing up. Okay. All right, and we're resuming recording right now. So I'll explain this stuff in the text in a minute, but there's some structures in the body that just make intuitive sense. And they're astonishing in their effectiveness, elegance, and simplicity. And I think the renal corpuscle definitely counts. So I already explained the sort of afferent and efferent arterial phenomenon, where if you just make the entrance larger than the exit, you create pressure in here. And then additionally, you basically have a cellular colander or sieve here. So the capillaries in the glomerulus are fenestrated. So remember, fenestrated is one of the few places in A&P terminology where we're using German instead of Latin or Greek. So das Fenster is window. So there's all these little windows in here. And then we've got the podocytes. So the podocytes are cells that sit on the capillaries and wrap their little pedicels around and around. And then those pedicels have pedicels, and it creates these filtration slits. And it turns out if you take an SEM of this, it's exactly like it is in the illustration. So it's very beautiful. But what it creates is this situation where we have this pressurized arterial-only capillary bed, which constantly is pushing fluid out. But there's a very specific and distinct limit on the size of things that can get through. So this creates a phenomenon where you're going to be able to filter out small things and keep large things. So this is why proteinuria is indicative of a malfunction in this apparatus, because these slits are so tiny that large proteins like albumins and like fibrinogen can't get through. So super duper cool, and it makes intuitive sense, right? We've all used a colander. You put liquid with stuff in it, and then the liquid falls through and the stuff stays in. Same deal here. Now, I do want to stress the podocytes as a group, because there's more than one per glomerulus, are also considered to be the visceral layer of the glomerular capsule, which is confusing to students. So let's take a moment to remind ourselves of visceral and parietal things for a moment. In any lining system, visceral layer of the lining system is the part that lines the thing, whatever the thing is, in this case, capillaries. The parietal layer is the lining of the space in which the thing sits. So podocytes are the names of these specific cells and their shapes. And together, collectively, they form the visceral layer of the glomerular capsule. So hopefully that disambiguates it a little bit. I remember early in my A&P teaching career when I was not great at it. That's a nice way of saying it. When I was a TA at Portland State, I remember trying to explain this strenuously to a bunch of A&P students who were looking at me like I was speaking in tongues because it was hard to explain. So hopefully I'm better at it now. The point I'm trying to make about the light microscopy, though, is that because we're shining light through a bunch of this stuff, you can see erythrocytes and whatnot, but you can't really distinguish in this mass of cells which nucleus belongs to a podocyte and which nucleus belongs to an endothelial cell. And so I don't expect you to either. So don't worry about trying to sort out which are glomerular capillaries and which are podocytes in this central mass of cells, at least not in an H&E stain, because you just straight up can't. Okay, so the Bowman's capsule consists of the parietal layer, which is basically a hollow sphere of squamous epithelial cells. Confusingly, and here you can see it as well. This is the first slide that we usually give students to try and figure out what squamous epithelium looks like. And then they're looking at it and they're like, it all looks cuboidal because they're looking at what's around it, not this thing. So we're talking about this right here. The visceral layer is, of course, podocytes, like I mentioned, and they have this cool shape. And then the capsular space is just the space between the two. So the capsular space is the first place that receives the newly filtered filtrate, essentially. And again, we can see some nice things here. And I'm going to actually use my little zooming in tool. So here we can see the vascular pole. And I know it's a vascular pole because we've got a macula densa here. And then there's a distal convoluted tubule. Here's a proximal. I'll teach you how to recognize these two as well, but the short answer is PCT cells have a very distinct brush border, which makes their lumen appear messy and disorganized, and distal convoluted tubules do not have the same amount of microvilli, so their lumen surface looks cleaner and tidier. Okay, so here's a nice picture of the glomerular filter. We've got the fenestrations, and then over the top of that, we've got the basement membrane, and then additional filtration slits. So it's a really efficient filter system that helps to reliably and consistently ensure that only very small amounts of tiny proteins or short peptides make it through and not larger proteins, and that the filtrate contains only the things in this sort of green blob here. So any disease process that either blocks this stuff or causes this to be too leaky is going to affect what's in the blood and affect what's in the urine. So one of the reasons that we use urine to make inferences about what's in the blood and also about general health is that sometimes urine can tell us whether the structural integrity of this filter is still in place or whether it's been damaged, i.e. proteinuria. So I mentioned earlier that diabetes long-term, if managed poorly, impact the kidneys. And I discussed the link between it and glomerular nephritis, but there's also another thing. It's called glomerular sclerosis. And this is basically the thickening and loss of function in the basement membrane. So essentially, and this is true for other diabetic vasculopathies as well, microvascular refers to tiny, tiny blood vessels. And one weird thing that diabetes tends to do is cause angiogenesis inappropriately in places that shouldn't be experiencing angiogenesis and make certain things thicker, stiffer, and full of blood vessels where there shouldn't be. So one of those places is the glomerular basement membrane. And so if you make this thing too thick, it changes the filtration properties and damages the kidneys permanently. So if this goes on long enough, what you end up with is someone who needs to be on dialysis and or have a kidney transplant. The other place where you get microvascular sclerosis in diabetes is the vasculature of the eye. And that's why diabetes can lead to blindness as well. So we'll talk more about that when we get to the histology of the retina, but it's the same problem, just in a different location, essentially. Okay. So mesangial cells. These are nifty. So this is a really nice drawing. So we've got podocytes, which are reaching out their little pedicels and processes, providing those filtration slits. And then in the capillary here, we can see the capillary endothelial cells nucleus, and then it's going to line right here. There are also mesangial cells, which are in between capillaries, and they cover any surface of the capillary that's not covered by podocytes. And interestingly, they appear to kind of reach into the capillaries and sample stuff that's in the capillary to remove any proteins that might be sticking there or anything that's going wrong. So they are integral to renal health, and they're not super well understood other than these roles. But they seem to be very important for a variety of reasons. One of them is this protein monitoring, but we'll discuss some mesangial cell stuff when we talk about the renin-angiotensin-aldosterone system as well. All right, so the uriniferous tubule, which is the fun way of saying it. So if you straighten the nephron out for illustration and teaching purposes, it looks like this. So we've got the urinary pole giving way to the proximal convoluted tubule, the PCT. And then we switch on over into the loop, and the loop has a descending limb and an ascending limb. And then we have the distal convoluted tubule on the other side of the nephron loop from the proximal, and then the connecting tubule, and then that leads to the collecting duct, which descends and collects urine from other DCTs along the way until it dumps into the minor calyx. So I mentioned earlier, the microvilli in the proximal convoluted tubules are distinct even in light microscopy. And these are for reabsorption of useful material primarily. So amino acids, glucose, other small ions and molecules that filter out at the glomerulus, some of those are useful and you want them back. You don't want to pee them out. We spend a lot of time doing catabolism to starches to make sure that glucose is collected from them. So it would be a waste to just immediately urinate it out, would it not? So we want to get that back. So that's a lot of what happens in the PCT. The nephron loop is really about two things. One, concentrate the urine, and I'll show you how that works in a little bit. And the other is get back water in large amounts and sodium chloride in large amounts. So after the break, I'll talk you through the countercurrent multiplier. But the short version is the thick segments actively transport sodium and chloride ions at the expense of ATP. And that sets up a gradient that draws water out of the thin segments. So these are very water permeable, but they're not salt permeable. The distal convoluted tubule is cuboidal epithelium without microvilli, which is why its luminal surface, the apical surface, looks tidier. And this puts the finishing touches on the urine before it's excreted. So the major acid scrubbing happens here, as well as a couple other things. And then by the time the filtrate gets to the collecting duct, it's fully urine at this point. And then it's going to exit via the papillary duct, which is just the duct in the renal papilla, the minor calyx, major calyx, renal pelvis, ureter, urinary bladder, and eventually the urethra and subsequently outside of you. So this is a lucky slice because here we can see the glomerulus, and then we can see the urinary pole leading right into the proximal convoluted tubule. So another name for the urinary pole is the tubular pole, but in this case, we got lucky and we passed the knife right through those, so you can see that they are indeed confluent, not visible in every single case. So the urinary space or the capsular space is just a little space between the two. The glomerulus is again this mass, and you cannot tell the difference between capillary endothelial cells, mesangial cells, and podocytes, so I'm not going to ask you to try either. And then we've got over here, we can see numerous distal convoluted tubules, cuboidal epithelium, nice tidy luminal surface, no microvilli, and then the much messier and more irregular looking proximal convoluted tubules. All that surface area makes for a disorganized appearing luminal surface. So that brush border is really messy looking. And then you can see peritubular capillaries all over the place. So that's where these arrows are. And these are places where anything that's taken out of the filtrate and put back into the blood is going to re-enter the blood. So like this one immediately abuts this this proximal convoluted tubule. So if I am like, oh, I need this glucose back, the glucose that I take out of the filtrate is going to get plopped right back into the blood here. So it's pretty cool what you can infer and observe just from light microscopy in this context. Okay, so I like this picture a lot because it shows you exactly where we're slicing. So the renal corpuscle is the glomerulus plus the capsule. And then we've got PCTs and DCTs. Another thing about PCTs is that the cells themselves tend to be eosinophilic, meaning they look pinker in the cytoplasm, which is nice. So you can look for two things. One is messy, disorganized luminal surface. The other is eosinophilicness, to distinguish between the two. If you see renal corpuscles, you know that you are in the cortex because there are not any renal corpuscles in the medulla. And DCTs and PCTs share real estate with the renal corpuscles. So if you see a picture that looks like this and you're like, oh God, okay, now I have to figure out what part of the kidney I'm looking at. If you see corpuscles, you can say cortex. And then the corollary to that is that you would expect to see only proximal and distal convoluted tubules in that area, which makes your choice of tubes much easier. Down here in the medulla, the tall cells are collecting ducts. And these are cuboidal to columnar. They become more columnar as they approach the papillary duct. And then we have thick ascending limbs, which again tend to be eosinophilic, as well as thin descending and ascending limbs. You can't necessarily tell which is which, but you can tell that they are thin. And if they do not contain erythrocytes, then they are not blood vessels. And then finally, just collecting ducts. So if you don't see any renal corpuscles, this is your choice of tubes. Okay, so now it is time to take a short break. And then when we come back, I will explain basically what happens in each tube region. So we're going to get into a little bit more physiology here. So as you gather your beverage, etc., just mentally prepare yourself for that. So you can sort of generalize this very complex process into 3 stages, which helps with understanding. And that is glomerular filtration is first. So this is the physical process of filtering fluid and sorting it from cells and proteins. Tubular reabsorption and secretion are considered one step because it's not like one happens first and the other happens second. They're happening simultaneously. And then water conservation is kind of happening the entire way because, of course, water is like your annoying sibling. It always wants to be where solutes are. So any place where solutes are being reclaimed, water will osmotically follow. So when does it become urine? Well, we consider the filtrate to be urine once it enters the collecting duct, because after that, not a whole lot changes. The only thing that's likely to change in the collecting duct is water content, and that is primarily the domain of antidiuretic hormone, which we'll talk about in the endocrine system a lot. But in the collecting system, for example, glucose ions, macromolecules, those are no longer moving. It's just water changes. Okay, so in the beginning stages, when we're doing glomerular filtration, it now makes sense to talk about the juxtaglomerular cells and the macula densa. So I'm going to actually zoom in on this part of the screen. Boop, there we go. So we've got the afferent arteriole and the efferent arteriole. And as you can see here in this illustration, much harder to see in H&E light microscopy, by the way, so don't stress about finding the smooth muscle there so much. As you can see, it's difficult, right? So you make constant little changes to your filtration by changing the pressure in your glomerulus. Obviously, if the pressure in the glomerulus is really high, we're going to be forcing lots of fluid out. And if the pressure is low, we're going to be doing less. So the speed at which you are making filtrate is called the glomerular filtration rate, or GFR. And GFR is a reflection of blood pressure, essentially. So the macula densa cells, remember, macula means spot, densa means dense. So this is Latin for dense spot, which is definitely borne out by the cytoarchitecture of this area. So these are some special cells in a little dot that measure what's in here and communicate that to what is in here. So we have juxtaglomerular cells, which are kind of wrapped around the afferent arteriole primarily, and they're in contact with these mesangial cells. So this apparatus is going to measure sodium in the DCT and how much of it passes by. And that's used as a proxy for the speed of GFR. So if you're confused by that and going like, what? That is totally fine. Essentially, the more sodium passes by, that indicates that filtrate is moving quickly. So that suggests GFR is high. And if less is moving by, then it's lower. So the macula densa is sensing flow and fluid composition. And if appropriate, it will send a paracrine signal. Remember, paracrine signaling is when a cell is secreting signaling molecules into the extracellular fluid, mostly to talk to its neighbors. So in this case, the juxtaglomerular cells are right next by, and that's who they're talking to. So the juxtaglomerular cells are specialized, modified smooth muscle cells. And essentially, if GFR drops, so we get a reduction in flow in the macula densa area, they're going to do a couple of things. One of them is secrete renin if there's a drop in blood pressure, and that activates the renin-angiotensin system. But they're also capable of altering the diameter of the afferent arteriole to control glomerular pressure. So we will talk about the renin-angiotensin aldosterone system additionally in the endocrine system, but here is your sort of prelude to that. And I actually am gonna take a moment to do some drawing here, just because this list is fine, but I feel like it will make more sense to you if there are pictures. So why don't we do this? And then let me detach my screen. Okay. And hopefully this is not too slow. Sometimes it goes really slow. If it slows down significantly and looks like it's going to crash, I'm going to just stop drawing, but I'm hoping for the best. So if we have, that looks pretty good, a drop in blood volume, that causes a drop in glomerular filtration rate. And what that's going to do is signal a decrease in flow in the BCT, and that's going to be sensed by the macula densa. So that's going to tell the juxtaglomerular cells to secrete renin. So let's take a moment to review our slide really quick. So renin is going to be the activating step of the renin-angiotensin system, and it's also sometimes called the renin-angiotensin-aldosterone system. So angiotensinogen is a liver protein. So it's one of the many things that your liver does. It's converted into angiotensin 1 by renin. So let's draw that out. I'm going to draw the liver over here. All right, big right lobe, small left lobe. And so this is going to be producing angiotensinogen. So by the suffix ogen, we know that it's a precursor. So it's not active in that form, but it can be activated if necessary. So you've got circulating angiotensinogen just waiting to be turned on by renin. So renin is going to facilitate the conversion of angiotensinogen into angiotensin 1. And then we have lung involvement. And draw some bronchi here. There we go. And so you might be wondering, like, what the hell do the lungs have to do with this? Great question. The lungs are where angiotensin converting enzyme lives. And angiotensin converting enzyme does exactly what it sounds like it does. I'm trying to pick the right red here. It converts angiotensin 1 into angiotensin 2. And angiotensin 2 does a bunch of stuff. So one thing it does, hence the name, is it decreases blood vessel diameter, which is going to increase blood pressure. It also initiates the secretion of antidiuretic hormone, which makes you thirsty and basically lowers the volume of your urine. So and then aldosterone is also acting on the kidneys, but in a different location. It basically causes the selective reuptake of sodium at higher rates so that water is going to follow. And that's going to help keep water out of your urine and in your blood. So this is why we call it the renin-angiotensin-aldosterone system. The other part of this feedback loop that is activated but not visible here is, in addition to renin, erythropoietin is also secreted to replace any red blood cells that might be lost. So that's the basics of the renin-angiotensin-aldosterone system. So you might actually be a little bit more familiar with this whole thing than you think you are. It would be cool if I could find my cursor. There we go. So have you guys heard of ACE inhibitors, the drug? I bet a lot of you have, right? So if you're not familiar, ACE inhibitors are a very common class of drug that are used to manage high blood pressure. So if you have chronic hypertension, you're going to be prescribed ACE inhibitors, and those, along with your physician insisting that you make some lifestyle choice changes, is what's going to help manage your chronic hypertension and bring your blood pressure down to a reasonable level. So a lot of people have heard of ACE inhibitors. Most people don't know what they do. What they do is inhibit the angiotensin converting enzyme in the lungs. So it helps prevent the conversion of angiotensin 1 into angiotensin 2. And that prevents blood vessel constriction, and it limits the amount of ADH and aldosterone that are possible, which facilitates the loss of excess blood volume urinarily. And that helps to bring blood pressure and volume down. I'm going to pause the recording here for just a minute because I had a brainwave. Yeah, I've been, if you're watching this recording in the future, I'm recording again now. If you're watching this recording in the future, go Google angiotensin 2 or angiotensin converting enzyme 2 and COVID-19 to investigate more about how what's on this slide relates to the global pandemic, but I'm not going to cover it in this video. But regarding the vaccines specifically, yeah, they do definitely generate a crummy immune response that is not enjoyable for most people, but it is indeed worth it. But anyway, it's always neat to know exactly why what you're learning matters. And there's an example. Okay, so it's not often that you get such a lucky slice, but in this case, you can see it. So here we have the afferent arteriole and efferent arteriole, as well as the macula densa. So this is incredibly fortunate, but if you slice enough kidneys, you get lucky, right? So you can see that the area around the afferent arteriole is thicker than that of the efferent, which is how you can tell. And that's due to the presence of these juxtaglomerular cells. So you can also see how close the macula densa cells are interacting with the juxtaglomerular cells, and that facilitates that paracrine secretion. And if you look, there are also lacies cells, which are mesangial cells that are among and between these capillaries near the macula densa. All right, so here we have a nice little sort of summary slide or table. Again, useful for exam taking purposes because it gives you a really nice rundown of the regions and what's there, but not your primary resource. Should be more of a quick reference. Okay, so upon delivery at the minor calyx, we don't really do much to the urine afterward. We just call it urine. The primary sort of alterations made after this point are in the presence of antidiuretic hormone, you get aquaporins put into the tubule, and that's going to cause the movement of more water out of the collecting duct and into the various capillaries in the medulla, and that facilitates water reclamation. So that's kind of how ADH works. So after that, we've got the minor calyces, major calyces, renal pelvis, and ureters. And this is where we get to talk about renal calculi or kidney stones. So it turns out not all calculi are created equal. It depends on their etiology. So there's calcium phosphate or oxalate, which is one kind of stone, or uric acid crystals, which are another. So why would we differentiate between these at all? Well, it turns out due to the crystalline matrix pattern of the crystals, the urate stones tend to be small and smooth, and in some cases will pass without much fanfare. But the calcium stones can basically they seed more quickly than the urate stones, and they tend to be spiky. So it's like having a little spiky ball that is trying to pass through your ureter, which is, as you might imagine, very, very painful. For whatever reason, kidney stones tend to be more common in males than in females, but they can absolutely happen in any sex. It's just this weird thing where they tend to happen more frequently in genetic males. Who knows why? Probably something to do with protein catabolism. But they hurt super duper bad. And they're often mistaken for back pain initially because of the location anatomically of the ureter. So you can get ones that are so bad that sometimes you have to have surgical removal, or this cool procedure where you can basically direct a focused beam of sound that destroys the stone. So that's called lithotripsy, which is interesting. But unfortunately, in most cases, the majority of the time, the doctor is just going to be like, wow, that sure does suck for you. Here's some pain pills. You're going to have to pass this at home. So a good way to avoid kidney stones, if you're prone to them, is to make sure that you're adequately hydrated, because crystals only form from super saturated solutions, meaning really, really concentrated urine. And you can also make sure that you're not, for example, over consuming things that might encourage crystals, including multivitamins. So you got to be careful with multivitamins. Oh, that's terrible. I'm so sorry to hear that. Let's, in honor of that person who is in the hospital right now because of one, let's look at some calculi. So I'm going to stop my share for just a moment and then pull up some pictures. I just don't want to show you any super graphic things by accident, but I will show you. The worst form of these. Oh boy, that is not good. All right, prepare for calculi. You're about to look at some. So these are called staghorn calculi. They're quite bad. As you can see, radiologically, you can distinguish. So here's a minor calyx. There's a major calyx. You can see the entire renal pelvis. This one is very large. So this would result in distension of the urinary collecting spaces and very much damage to the kidneys. Here's what they look like when they come out of you. Obviously, this is too much for lithotripsy. You would need surgery at that point. It does indeed look like ginger. I'm sorry if you have ruined ginger for yourself, but I'm still chill with it. But yeah, as you can see, this is very, very bad. Obviously, most calculi don't advance to this stage. Most of them are passable, but this is an extreme example of a calculus, and it's called staghorn due to its radiologic appearance. It looks kind of antlery or gingery, depending on what you see when you look at it. So this is an example of an extreme version of that. Most of them don't get that bad. Okay, so let's have a look at the collecting ducts. So remember, we are now in the medulla, so you would not expect to be seeing any PCTs or DCTs anywhere near this. And as I mentioned as well, sort of proximally in the renal medulla, so closer to the distal convoluted tubule, the collecting duct is more cuboidal, but as you proceed more distally in the renal tubule, so towards the renal papilla, the collecting ducts become what we call papillary ducts, which have more columnar cells. So there's this gradual transition to more and more columnar cells. So I remember I mentioned that we can kind of change the concentration of the urine by putting aquaporins into the collecting system. So those are initiated by ADH. So what antidiuretic hormone does is it comes in and tells these cells to synthesize and place in the membrane little holes for water. And then because the concentration of the interstitial fluid outside of the duct is very, very salty due to both sodium chloride and urea, osmotically, the pressure is high here, so that the water really zips through and out. So here we can see the collecting ducts. Here's the vasa recta. So you would see water going from here through the aquaporin and directly into this blood vessel. Fun fact about antidiuretic hormone, it is inhibited by alcohol profoundly. So if you are imbibing and you find yourself peeing a lot, it's not just because you're consuming extra fluid, it's also because your endocrine system does not like booze. So you end up peeing a lot more than you would ordinarily, and that's incredibly dehydrating. So really what a hangover is, assuming you haven't given yourself alcohol poisoning and it's just a regular hangover, is an extreme state of dehydration, and the headaches associated are typically due to low blood volume. And you lose a lot of electrolytes that way as well. So every culture has its unique hangover cure that vary in severity. Like, you know, you might be like, there's a lot of egg-based hangover cures. But the most medically reliable way to avoid a hangover is not to imbibe so much in the first place. But if you must deal with one, Pedialyte and Gatorade are your best friend. Or if you're a fancy rich person that can afford one of those IV services, that. But yeah, I agree with the chat. The best bet is to alternate alcoholic beverages with water. And no, mixers do not take the place of that. And, you know, moderation in all things, including moderation. My favorite alcohol fact, I think, is that it actually lowers testosterone because it has a toxic effect on Leydig cells in the testes, which was very shocking and disturbing to some of my more alcohol-friendly testicle-having friends when I was like, you know, it actually has a negative effect on your virility, so maybe cool it on that. Yeah, so booze, be careful of it, but enjoy it if you like that kind of thing. Okay, so we're about to get, I just talked about negative effects of alcohol on testicles, but now we're about to get kind of gross because we have to talk about bacterial pyelonephritis. So pyelo is the prefix that means pus, and that's why I warned you that we were getting gross. So essentially, your urethra is open to the outside world, and usually a combination of urethral secretions as well as acidity of the urine prevents bacteria from colonizing the urinary tract. However, sometimes bacteria get the best of us and then you get a urinary tract infection. If that's managed poorly, the urinary tract infection can climb up the urethra, go through the bladder, and end up actually going all the way up to the pelvis and calyces. So obviously that's really bad, but what ends up happening is, of course, we get neutrophil and macrophage invasion because they're going to go try and fight the bacteria. And then as that happens, some of them end up dying. Dead white blood cells is what pus is made of. So although it's icky, it has a function. It's your little dead crusaders against disease. And this basically causes your collecting ducts to fill up with neutrophils. So that's not great. And this is when you might have to go to the hospital and also be prescribed some fairly heavy duty antibiotics. Okay, let's look at the ureter. As you can see, there is the mucosa, which is transitional epithelium, as well as an inner circular and outer longitudinal layer of smooth muscle, which assists the passage of urine by peristalsis, although most of that work is done by gravity. But as you can see, the lumen is irregular. It is what we call a stellate lumen due to the elasticity of the transitional epithelium. And so if you imagine a spiky calculus traveling through here, it's really easy to see why that might be painful. There's just not enough space for the thing to move smoothly. So if you see a transitional epithelium plus 2 smooth muscle layers, you're looking at the ureter. There's also smooth muscle and transitional epithelium in the bladder. However, the detrusor muscle, which is the name for all of the smooth muscle layers of the bladder, is much, much thicker. And the mucosa and lamina propria of the bladder in a relaxed bladder are thrown into these folds, which are not present in the ureter. So even though they have the same histological makeup, their structural arrangement is different, which is how you can tell. So urothelium is another way to talk about transitional epithelium, so you can consider those to be functionally interchangeable terms. There is a lamina propria underneath, which is sort of loose connective tissue, and then there's a relatively thin submucosa. And then we have outer layers of smooth muscle. Officially, there is an inner, middle, and outer layer. However, as you can kind of see, they appear disorganized, and that's really because the layers kind of descend around and through each other, not unlike a ball of yarn, kind of. So in many locations on the bladder, you would not expect to see them that organized, let's say. When the bladder is full, the urothelium is thinner and the folds are less present. So this would represent a full bladder. And when it's empty, you can see the urothelium and the mucosa and lamina propria are relaxed into folds. And these umbrella cells, which are at the top, have a dome-shaped appearance, which is the most classical sign of urothelium. So cystitis, sometimes called interstitial cystitis, is a problem where the bladder mucosa, and this can be the epithelium, but it can also be the lamina propria, is inflamed. And because stretch receptors in the bladder are what signal the central nervous system that urination is necessary, one of the most annoying things about cystitis is the feeling of needing to urinate and then going to the restroom to urinate and nothing happens. And it's because you didn't really have to pee. It was an inappropriate stimulation of your receptors due to inflammation. So it's not only painful, it's urinarily confusing and frustrating. And it can be caused by a variety of things. So catheterization is the most common nosocomial cause, nosocomial meaning hospital acquired. But immunodeficiency is another one. So people who take anti-rejection drugs due to organ transplants are at an increased risk for cystitis, as well as people who have poorly managed HIV. And then radiation or chemotherapy as well. Bladder cancer is not uncommon, and unsurprisingly, it usually originates in the transitional epithelial cells. And of course, that's because, as we've discussed previously, highly regenerative tissues are at an increased risk for cancer because statistically, the more often a cell divides, the more opportunity there is for errors. Okie dokie. So we have, oh, we're good. We have about 20 minutes left. So we can get a fair amount into the endocrine system. So one of the things that is frequently mistaken for a glomerulus and tubules in histology, particularly among my A&P students, is pancreatic islets and exocrine acini of the pancreas. And you can kind of see why, right? Because it's like a ball of cells surrounded by some clumps of cells, and there's a passing resemblance. So in order to avoid that confusion, what I would recommend doing is having 2 windows of histology guide open side by side and looking at them and visually comparing and contrasting. One of the benefits of doing online histology is you have this unique ability to look at 2 different slides directly side by side and see how they're different, which is not a benefit that you have for in-person histo. So it's a reason to count your blessings, even though there's a lot of stuff about online learning that kind of sucks. So the endocrine system is, not gonna lie, my favorite. And one of the reasons for that is that within a human lifetime or a vertebrate lifetime, there are 2 time frames, and both of them are necessary for survival and reproduction, and they have to work together. So what I mean by that is there's the acute time frame, which is mostly handled by your nervous system, so stuff that has to happen fast. Things like autonomic regulation, fight or flight, reflexes, movement, perception. Those are primarily handled by the nervous system. But since we live longer than a mayfly, there are also life history events that are many years in the making. So notably, puberty is a big one. And as we discussed previously, second puberty for people that are transitioning, especially if they're transitioning later in their life, as well as changes in reproduction with senescence and aging. So menopause, for example, as well as a bunch of other things. So long time frame things are handled by the endocrine system. And then fascinatingly, anything that's kind of intermediate is handled by a handshake between those 2 systems working together. So you're going to hear me say the term neuroendocrine probably a lot, because that's that intermediate zone. And scientifically, it happens to be an interesting place to study, which was my specialty when I went to graduate school. So that's why I have an implicit bias towards it, full disclosure. So again, if I sound like I'm like really nerding out about this stuff, it's because I 100% am. I know it's weird to get excited about such things, and yet that is the kind of person I happen to be. So endocrinology is the study of this system and the treatment of its disorders. But of course, an increasing field in endocrinology is helping people who are transitioning manage their transition. You know, we have to prescribe hormones and or hormone analogs, and not only that, in the right timing and in the right doses to affect the transition that is desired. And that requires a deep understanding of endocrinology. So that is a medical specialty. So it's not only diagnosis and treatment of disorders, it's also important for gender and identity affirming hormone replacement therapy. So endocrine glands are organs that are traditional sources of hormones. It's a little bit reductive though, because nearly all of our cells and tissues have some endocrine function. So this is another reason why the endocrine system is so fascinating, because, you know, we have like the thyroid gland, the gonads, the adrenal glands, classical endocrine glands, but we've also got diffuse endocrine tissues all over the place. So we did talk about some of those in the digestive system, for example, your adipose tissue. So we've got leptin, all kinds of stuff. So endocrine function abounds. Even your heart is technically an endocrine organ as well, because it releases atrial natriuretic peptides. So how hormones work is they are chemical messengers, and they have varying classes chemically that endocrine glands dump into the bloodstream. And then the chemical messenger will circulate in the blood and land on receptors on its target tissues and affect some kind of change, often quite far away from the place where it was initially released. This bloodstream delivery method is powerful because of two things. One, blood goes everywhere. And two, it allows the hormone to circulate and circulate and circulate, which prolongs the time during which it can be effective. Okay, so let's just make sure we understand endocrine secretion. Exocrine glands are glands that secrete some kind of goop. So think of exocrine secretions as goop based. I know that's imprecise, but I think it's the best way to kind of make sure that that is internalized. So sweat, mucus, snot, tears, digestive juice, all of these are goops that are secreted onto a mucosa. We call these external secretions. This happens via ducts. And so ducts are kind of a defining feature of exocrine glands. Endocrine glands do not have ducts. They basically are very vascular organs, or they're close to a blood vessel, and they dump hormones directly into the bloodstream via having those hormones kind of diffuse into the interstitial fluid and then diffuse into the blood. We also have paracrine signaling, which is ways for cells to talk to their neighbors. So this happens a lot. We don't focus on it here because it could be its own class, honestly. So could endocrine stuff, but and then autocrine signaling is when a cell talks to itself, which seems weird, but it's common. So an example of an autocrine secretion is a cell being like, hey, you should undergo apoptosis, and then the cell responding, oh gosh, yes, I sure should. So the hypothalamus and its relationship to the pituitary are one of those places that I mentioned where there's a handshake between the nervous system and the endocrine system. And that's because, of course, the hypothalamus is part of the brain and therefore part of the central nervous system. And also, the pituitary itself is a weird hybrid gland, and we'll talk more about that in a little bit. So the pituitary and hypothalamus together are the masters of the endocrine system because endocrine commands issue from these two structures. So this brings us to the idea of an axis. So you're going to hear me talk about endocrine axes. What I mean when I say that is the hypothalamus tells the pituitary to make a hormone. The pituitary makes a hormone, and that hormone tells another gland or tissue to make its own thing or do something. So for example, the relationship between the hypothalamus, the pituitary, and the adrenal gland is called the HPA axis. There's also the HPG axis, which is hypothalamic pituitary gonadal. So if you are an endocrinologist, understanding dysregulation involves making sure that you understand each axis and its feedback loop, because the hormones feed back on the structures that produce them to inhibit their own production. And that's what helps keep our hormone levels more or less normal. So when you have too much or too little of something, it is your endocrinologist's job to look at what's going on with you and infer what part of the feedback loop is broken. So one of the coolest things about this weird relationship between the hypothalamus and the pituitary is the different developmental origin. So the hypothalamus is directly connected to the posterior pituitary because the posterior lobe of the pituitary gland is a downgrowth of the brain. So during fetal development, essentially the diencephalon reaches down and expands to form this little bulb, and that's what ends up being your posterior pituitary. So we're going to have to sort of think back to what we know about the nervous system for a minute here. We've got neurosomata, which are cell bodies. And as we know, the soma is where the nucleus is. The reason that's important is because you have to make proteins or peptides near the nucleus. Remember, the nuclear envelope is continuous with the endoplasmic reticulum, and that's where there's a bunch of ribosomes, yada, yada. So this is the peptide synthesis location. As you can see, the axons of these neurons terminate in the posterior pituitary. So we've got the paraventricular nucleus, which is next to the third ventricle. That's why it's called paraventricular. And then the supraoptic nucleus, or SON. So we have PVN and SON. The supraoptic nucleus is called that because it's right above the optic chiasm. Optic chiasm, remember, is where your two optic nerves cross. So these are two populations of neurosomata that give rise to two different populations of axons. The axons associated with the paraventricular nucleus are the oxytocin ones, and the axons associated with the supraoptic nucleus are the ones that release antidiuretic hormone. So oxytocin and antidiuretic hormone are released in response to action potentials traveling down through the infundibulum into the posterior pituitary. So they are released like a neurotransmitter is released. Action potential opens voltage-gated calcium channels at the axon terminus, and the peptide hormones, oxytocin and antidiuretic hormone, are released. Oxytocin and ADH both are very, very short. I believe they're both nonapeptides, meaning 9, but I'm not 100% on that. I know that arginine vasotocin, which is a ADH analog, is. I can't remember oxytocin. I think it's either 8 or 9. So this is an example of that handshake between the nervous system and the endocrine system. We've got hormones, which are released into the blood, but they're released by neurosecretory neurons, which behave like they're releasing neurotransmitter. So gray area here. Now we've got the hypothalamo-hypophyseal portal system. So the superior hypophyseal artery gives rise to a capillary bed that wraps around axons associated with, again, neural cell bodies in the hypothalamus. But these axons don't travel all the way down to the anterior pituitary. They terminate in the hypothalamus on this top capillary bed. And these are going to make things like releasing and inhibiting hormones. So the hypothalamic hormones in this purple box are the releasing or inhibiting hormones. So they're dumped out of the axon into the bloodstream up here. And then those hormones travel down the hypophyseal portal venules into the anterior pituitary, where they diffuse out of the blood, land on the cells of the anterior pituitary. In response to that binding, the anterior pituitary hormones will secrete their own secretion, which goes again into the blood and then out via the venules, the efferent venules. So an example of how this works would be gonadotropin releasing hormone is released up here. It travels in the blood to the anterior pituitary. The anterior pituitary, in response to experiencing binding of GnRH, is going to release follicle stimulating hormone and luteinizing hormone, which travel to the gonads to do things like stimulate spermatogenesis or follicular development in the ovaries, cause the secretion of testosterone and estrogen, yada, yada, yada. So communication between the hypothalamus and the anterior pituitary is blood-based and involves a portal system. Communication between the hypothalamus and the posterior pituitary is neural-based and resembles more closely the release of neurotransmitter. Okay. So if you have taken A and P, you might remember from skull anatomy. Remember how intimidating that was? When you were like, oh, I have to learn all of these holes? Oh my God. You might have also had to learn the sella turcica. So if you don't know, the sphenoid bone is a weird moth-shaped bone that is deep in the center of your head. In the center of that bone is a dent, and that dent is shaped like a Turkish saddle, which is what sella turcica means. So the anatomists who are naming all those bits were like, aha, that resembles a saddle I saw in Turkey, and so it shall be. So that is a little bony pit that protects the pituitary gland, and it's where it sits. It's also why, if you happen to need pituitary surgery, they have to peel your face down and access your pituitary through your face bones, which is crazy. But it's true, and I've seen it done before, so it's hard. It's a hard gland to get to. So in the last few minutes before we end, let me just tell you a little story about when you were an embryo. So first you were a single cell, that's a zygote. And then when you were at about the 16 cell stage, you looked like a raspberry, which has a fun name. So you were called a morula. And then after you were a morula, you were a blastocyst, which is a hollow ball of cells with a little bit more order. And then after you were a blastocyst, in your early stages of embryonic development, you were briefly kind of a sandwich with an endoderm, ectoderm, and mesoderm. And then from that sandwich, you began to sort of turn into a tube. We do that butt first. We're deuterostomes, which is Latin for mouth second, but implies that your butt formed first, and it did. We come into this world anus first, literally. That's what being a deuterostome means. So after you turned into a fun tube, you began to wrinkle. And gastrulation is the name for that tube formation. So after you gastrulated, when your mouth was forming, a little bit of your pharynx, the back of your mouth, started to pouch up. And that pouch began to reach upwards towards your brain. Meanwhile, your brain, which at this point kind of looks like a baseball bat that is kinked in several places, the part of your brain that is associated with your diencephalon begins to grow downward. And that is going to end up growing into your hypothalamus, your infundibulum, and your posterior pituitary. So that little embryonic pharynx pouch reaches up, it grabs onto the posterior lobe and sticks to it. So the pars distalis is what happens after that pinches off. And then the pars tuberalis is basically the anterior lobe wrapping its little hand around the infundibulum during embryonic development and then hanging on for dear life. As development proceeds and you begin to have ossification processes, your sphenoid bone forms and it separates your pharynx from your skull insides, and that forms the sella turcica. And it also sort of entombs your pituitary in this protective bone and cuts it off from your mouth. So the reason I'm being so intentional about how I describe this is because the posterior lobe is literally a brain downgrowth, which means histologically, it is neural in appearance. The anterior lobe, by contrast, is epithelially derived because it comes from your mouth. So it looks like a glandular epithelium. So you have this weirdo gland that is a composite of two completely different tissue types because it embryologically came from two completely different tissue types. So when I earlier mentioned a handshake between the endocrine system and the nervous system, I was kind of being literal because, as you can see, the two are directly holding on to each other in this gland that is basically executing all of the commands of the rest of the endocrine system. So the little pouch is called Rathke's pouch. And the best way to find the pars intermedia is to look for this little split called a Rathke's cyst. And then on the other side of the Rathke's cyst from the anterior lobe is the pars intermedia, which is right here. And that releases melanocyte stimulating hormone. So all kinds of cool stuff you can observe just as sort of a leftover of development from this little dealie. All right, and with that, we are out of time for today.